and thank you for joining us today. I'm Dr. Jennifer McDonald, and I'm the lead for the Mission Act in the Veterans Health Administration. We're glad you joined us today, and we invite you to post your questions in the comments as we continue. I'm here with VA colleagues and Veteran Service Organization representatives, and we're here together today to make sure that you have the right information about the Mission Act changes launching on June 6th and about the beginning of VA's future that starts on that day. With that, I'll introduce my colleagues. Dr. Cameron Matthews.
Good afternoon. My name is Cameron Matthews. I'm a family physician practicing in the VA, and I'm the Deputy Undersecretary for Health for Community Care.
Hello, I'm Shanin Nunsbong, retired Marine Gunnery Sergeant, currently the Director of Veterans Affairs and Rehabilitation for the American Legion.
Good afternoon. My name is Jose Ramos. I am a medically retired Navy corpsman and also one of the 3 legislative directors for the Wounded Warrior Project.
And hi, I'm Sherman Gillums, the Chief Advocacy Officer for AMVETS. I'm also a retired Marine Corps Chief Warrant Officer.
And we're so glad to have you with us today, especially representing many of those watching. And with that, I think let's launch right into questions and make sure that we get all of the Mission Act information we can out to the people who need it today.
Yeah, I think the first question would be, what is the Mission Act and how is that going to impact my VA care?
Great question. The Mission Act truly is landmark legislation. It was passed in a bipartisan manner by Congress with strong support and input from veteran service organizations. And it's really a law that VA welcomes. It strengthens VA and it strengthens our ability to deliver the right care at the right place and the right time for veterans. Veterans will see an increased use of telehealth across the country, the ability to bring the right care to where they are, even into their living rooms. I'm looking forward to that as an Army veteran myself. I know that many of those I served beside will be able to get the care right where they need it, right in their own home. And this also streamlines our community care programs and brings more excellent options closer to home. Those are the major changes that veterans will see, and there's a lot more to talk about today yet too.
So to follow up, for a veteran who uses the VA now, come June 6th, when choice ends and Mission Act starts, do I have to reestablish eligibility? Do I have to do something different before I continue to see the same providers I see now?
Such a great question. And that care will continue. The same trusted providers and care teams that veterans engage with now, whether that is in VA's direct system of care or whether that's in the community, will continue.
Exactly. There's no additional enrollment. Once you are enrolled with VA and once you work with your care team, you'll just have increased ability to access the community in order to meet your needs.
Now, by now, many veterans have received that letter and that brochure. I did, my wife did, so did these gentlemen. On June 6th, a lot's going to happen. But when I walk into a VA medical facility, what are those new benefits I should expect to see?
Great question. Mine came in the mail as well, and I'm so glad you brought up that brochure. My daughter actually opened the letter, and it was her birthday. She thought she got a Mission Act brochure for her birthday. The new benefits in there's a lot of good information in that brochure that we encourage veterans to take a look at. And that brochure also directs them to missionact.va.gov. I'm just going to pause for a moment to spell that out. That's MISSIONACT, missionact.va.gov. That's where the most updated information will be. And importantly, that brochure discusses a new urgent care benefit that gives veterans the ability to seek urgent care in locations close to their home as long as they've used VA care in the last 24 months. So that means VA direct care or care in the community. As long as they've accessed VA in any form in the last 24 months, they're eligible for that urgent care benefit. It is really important, though, and that brochure says that veterans look at who is in our network and look on va.gov or ask their VA facility for those urgent cares that are in the VA network and participating with VA. That's one of the new things they'll see.
We're really excited actually about this urgent care benefit because again, it provides care closer to home. It gives you a opportunity other than an emergency room. Sometimes on off hours, you just have a question. You need to have an issue addressed. And it's somewhat minor. It's an illness, maybe a slight injury or so. And an emergency room sometimes seems off-putting. These urgent care centers provide a great opportunity for veterans to have their needs addressed But it is worth reiterating again that it does need to be with one of our contracted providers. In addition, we don't look at urgent care as a substitute for the relationship with a primary care provider. Again, actually both of us as family physicians
Yes.
and the entirety of VA, we really do value that relationship for kind of the longitudinal management of care with the primary care provider. So urgent care is meant to supplement, meant to help when there's maybe a quick issue that needs to be addressed with, but it's not supposed to be looked at as replacing that relationship with your primary care provider.
So I'm aware that there's a copay at a certain amount of visits in urgent care. Can you explain that to us?
Sure. And this can definitely be complicated, so this information is available on the website, definitely. But just to summarize it, basically, if you have a copayment currently with VA or in the community, you will have a copayment for urgent care, and that is equal to $30. For those veterans who are in priority groups that don't have copayments, your first 3 visits will remain without copayment. You will be able to access again, with one of our contracted providers without any copayment. But on the 4th visit or more, you will also be charged that $30 copayment as well.
So I'm going to change it a little bit as far as the topic, but really quickly, is that 3 visits per year, or is that 3 visits in their lifetime?
3 visits per calendar year.
Per calendar, perfect.
Good question.
So just Wounded Warrior Project interacts with a lot of obviously wounded, ill, and injured service members, and since the beginning of our conflicts in 2001, we've had over about 17,000 amputees. And a lot of our amputees are currently going to some to VA, a lot to community providers, and obviously some to military treatment facilities. Does where you get prosthetics change?
It actually does not. And in fact, there's more opportunity now to perhaps get it with a community provider because you have increased eligibility, which we can get into the details about, but increased eligibility to go into the community. But otherwise, who you are seeing currently will not be affected. Continuity of care is definitely meant to be preserved. As usual, as it has been in the past, any prescriptions for prosthetics or any other equipment would return to the VA for us to provide that equipment directly to you as a veteran, as opposed to through the community provider. But your care relationship is definitely not changed.
And the other elements of the Mission Act that is one of the best parts of it, we think, is the ability to increase our telehealth options for veterans, especially those who may have a more difficult time accessing us and coming into facilities. And we'll have a better ability to meet veterans where they are, in their own living rooms, in their own homes. And so what we'll have the ability to do in the future is pair that expanded network of community providers that are close to home with telehealth options to really wrap that comprehensive set of options around the veteran and make things easier and more convenient for them.
So this brings me to our question. Those of us who have used the VA for a while have seen care delivered in many ways. It's been defined by many terms. We just had the Choice Act passed in 2014, but there have been other ways that care was paid for. Now we've got this concept of community care, in quotes.
Yes.
How is that defined under this law? When we say community care, what exactly are we talking about?
Exactly. Great question. Just to clarify, community care is when enrolled veterans need to access services outside of VA facilities by non-VA providers. It's an opportunity to assure that we're actually meeting your need when, unfortunately, VA may not be able to provide those services. Either we don't have the necessary providers to address your issues, or it's inconvenient. You are otherwise too far away from a VA. VA doesn't necessarily cover the full geography of the country, so community care provides you the opportunity to receive those services if VA doesn't provide it and is not close enough to your home in order to provide those services directly.
And I think it's important to at least point this out, the way care is paid for, because I believe that was part of the problem with some of the
Yes.
other ways,
There you go.
some of the late payments that doctors would receive, or if they got them at all. How does this resolve that aspect of what broke down in the Choice Act model?
Great question. So a couple of different issues there. So yes, under the Mission Act, and this is getting into a lot of details, community care is consolidated. Like you mentioned, there's multiple programs that have occurred over the years. We now have a single program. The Choice program is expiring. Those eligibility criteria apply to any type of community care. And there's one funding pot to pay for that. On the provider side, in the community, we also have new rules set up by the Mission Act and that are also included within our contracts where we develop these relationships with community providers, where we have to pay them timely and we also have to pay them accurately. So we know that by not doing so, by not being a good partner to these community providers, we're threatening access to care, right? There are providers out there that have stopped seeing veterans because they aren't getting paid timely, and that is a problem, and we know that VA needs to be a better partner in that regard. So yes, Mission Act definitely puts it down in law that we will be a better partner, and we're already doing so also through our contracted networks. Currently, Tri-West helps us nationwide in making sure that community providers are available for us and they are paying claims timely, and we're proud to say that VA is making moves in other regards as well too to make sure we're a strong partner.
Mm-hmm. And Dr. Matthews might not say this for herself, but she's led incredible progress and strides and making up that service recovery with some of those providers and bringing them back into the networks that we're building now and that will launch on June 6th. A great deal of progress here and really strong options that people will see in their local communities moving forward.
Our veterans, 82% of our veterans prefer care inside the VA. But what about those veterans who are outside of this requirement? What are the requirements to see a provider outside of the system?
Sure. So we call those our eligibility criteria. And there are 6 different criteria that allow a veteran to access care. So there's very individualized approaches. So every veteran could qualify under a different piece of the criteria. First, does VA offer the service, period, in any of its facilities? Right now, VA doesn't offer maternity care or in vitro fertilization or hospice services. There's a list. Automatically, veterans that need those services are eligible to go to the community because VA doesn't offer those services. Second, does the veteran live in a state that does not have a full service facility? We have several states in the country that maybe just have outpatient clinics. They don't provide surgical procedures and the like. New Hampshire, Alaska, Hawaii are examples there. So veterans in those states are automatically eligible to the community. Then the choice program, as we mentioned earlier, it's coming to an end next week on June 6th. But there is one eligibility from the choice program that will continue on. That's what we call the grandfathered eligibility. Those veterans are grandfathered into the new community care program. That's particularly only the distance eligible veterans. So if you lived 40 miles or more than 40 miles from a primary care physician in the VA system, you were a 40-mile eligible veteran under the choice program. If you used it in the last 2 years, you can continue on with that eligibility. It's not permanent eligibility, however, it's just meant to help us transition into the new program. There are 5 states, however, that do have permanent eligibility, and that information is available on the website. One of the new criteria, and one that we think is actually most appropriate as clinicians, is called best medical interest. Between the clinician and the veteran, they can decide whether it makes most sense, whether it's in their best medical interest to go to the community. Will it actually impact their health, whether or not they stay in the VA or go into the community? So the decision can be made jointly, and we can make sure that the veteran receives the services they need if it's in the best medical interest to go be seen in the community. And that doesn't necessarily need to just be about a particular provider, although that could be the case. It could be that you want to continue a relationship with a provider that you've been seeing, that you've had established in the community. It's in your best medical interest to continue with that provider. We don't want to disturb that relationship. It could be based on some hardship that you cannot travel to the VA, and we otherwise deem it to be your best medical interest for health reasons to not make that travel to the medical center, but instead be seen in the community. There's many different possibilities under best medical interest, and we've provided VA providers with some guidelines about that, but otherwise it's a decision to be made jointly between the veteran and the provider.
And as Dr. Matthews said, we love this as providers because this gives us more tools to be able to do the right thing for veterans. This gives us the opportunity to really have a conversation that empowers that person who might be right in front of us at a facility, who might be on the screen via telehealth, but to have a conversation with that veteran about what is really best for you and how do we make this convenient, how do we do what's in your best medical interest, that's the right healthcare decision for you, that's the right, as you said, continuity of care decision for you. And this gives us more options. This is the flexibility that we all, I think, most of us went into medicine for, to be able to do the right thing for the person in front of us, and this gives us the better ability to do it.
Yeah, it's very exciting and it's different. So those are 4. I have 2 more criteria. This is complicated. We said it's
It sure
complicated. And
is.
again, that's why it's good to look at the website to make sure you understand eligibility, because the critical part is you should understand the eligibility before you access care, because we want to make sure that we're responsible with how you actually receive that care. So let's get into those last 2 criteria. There is the ability for VA to declare eligibility when perhaps one of our clinics, one of our service lines, is not meeting specific quality standards. It's meant to be a way that we can assure improvement in those clinics by offering the veterans the ability to go to the community if indeed quality isn't at a certain threshold, but then remediate, provide that clinic the opportunity to make improvements, and of course then have the veterans basically return home, return to the VA. Then lastly, the criteria that probably has the most attention in the media and in conversations are what we call our designated access standards. These are defined criteria by either wait time or drive time, where if VA doesn't provide the care within those drive time or wait time, the veterans can access eligibility. So for drive time, primary care and mental health, VA has to offer it within a 30-minute drive time of your home address. Otherwise, a veteran is eligible to go to the community. For specialty care, 60 minutes, because specialists are a little bit more rare even in the community, and there's just the expectation that we need to offer those services, but to a larger geography. Then for wait time, if VA can't get you an appointment in primary care or mental health within 20 days, you're then eligible to go to the community, or if we can't get you a specialty appointment within 28 days. Those are the access standards. So of all of those different criteria, we're happy that we're actually providing more access to veterans to go to the community, but it's just eligibility. The veteran can choose to stay with the VA. We know they do choose to stay with the VA. VA provides benefits and holistic care that is unlike any other health system in the country. And the point is that the veteran now has the decision, the choice to either go to the community or choose to stay with VA.
Well, I appreciate you touching on all the different criteria.
It's a lot.
Winter Wear Project, we survey our alumni every year, and what we have found is a lot of our alumni have both eligibility for DoD and for the VA, right? And so what that means is that there is a population of them that don't necessarily utilize the VA, although they're eligible for. Come June 6th, are they, if they have not been in the VA system within the last 2 to 3 years, are they eligible to start using community care right away?
Yes, they are. If they're enrolled in VA, they are eligible for VA services, and community care is just one of those services. Yes.
Yes, exactly. And just one important point about a couple of the things you've just heard. We touched on the Choice Act coming to an end. Just want to make sure we get across, especially to our listeners, that as the Choice Act is ending, as you asked earlier, there won't be that gap in care. Care will continue with those same trusted providers and care teams you've had. As Dr. Matthews said, if people are coming in, they've been enrolled in the system and have eligibility for using our system but have not accessed the system, they certainly can start that right away. The right place for those care questions is with that care team and with that provider that they trust. That's the place to start, because a lot of the community care eligibility depends on the distance, as Dr. Matthews was saying, to the care that's needed. So for instance, eligibility to go to the community for cardiology would depend on the distance from that veteran's home to that cardiologist. And so the place to start for whether that care is needed is with that trusted VA provider and care team that can help the veteran navigate through that system.
To highlight though, and I think maybe a point we do need to specify, is that if a veteran has not been using VA services within the last 24 months, they can't necessarily access the new urgent care benefit.
That's right.
And that is a different point. They can access community care, they can be seen by their care team and receive a referral to the community. But urgent care, where they can access our urgent care network without authorization, without contacting the VA, they have to have used the VA within the last 24 months.
Yes. And for those listening, as you hear, this is complex.
Yeah.
We do encourage you again to go to missionact.va.gov and seek more information, talk to your providers and care teams, and talk to your Veteran Service Organization representatives who have much of this information for you as well. We do encourage you to find that information. This is complex, and we're here to help you navigate through it.
I have a follow-up question on, can I go onto my specific map service on my computer and figure out whether I'm 30 miles or not, or is there a certain way, does VA have that control?
So VA has a system in which we do the calculation actually, and it helps us document and track those decisions, and it actually takes a good amount of data into account in order to make that calculation. So it's not exactly the mapping tool on your computer, unfortunately. What we are moving towards is a more refined tool over the next couple of months as well too, and we will publish publicly what the changes in those tools are. But the idea is to start taking into account traffic patterns and the like so that drive times can be more accurate. But we're actually going to be adjusting that tool to even adjust to traffic patterns changing by season even over time. But we'll publish that publicly and make sure that everyone is aware of that over time.
Great.
I'm encouraged by the idea that we're promoting discussion between provider and the veteran is empowered to have a voice.
Yes.
I think that may have been missing in many cases. And there are a lot of things that need to be discussed, and a lot of them will be situational and perhaps subjective, and not every veteran will be happy with every decision.
True.
And in that case, the AMVETS places a high value on having the opportunity to be heard. You may not get the outcome you desire, but there's an opportunity to be heard. Sometimes that's satisfying. Under this new Mission Act, which has a lot of moving pieces, a lot of things that need to be understood, if there's a disagreement, how do I reconcile or how do I deal with that disagreement if my doctor or some VA staff person hands down a decision that I don't want to accept?
That's such a great question. That first place is that provider and care team to have that discussion, and as providers we know that we make every effort to do what's in that person's best interest and make sure that those needs are met. And if in fact it needs to go to a further step, there is a process, and I'll hand this to Dr. Matthews in a minute, to make sure that we take a relook at the eligibility, if that's the topic of the conversation, is the specific community care eligibility, and that we walk through the clinical appeals process if indeed this is about care. So there's two pathways. Both of those start with the patient advocate at the facility. And again, those care teams are making every effort to make sure that those needs are met first, but the patient advocate is there in case there's anything further that needs to be resolved.
Sure. So with the patient advocate, veterans can file an appeal. And the concept is if it is about the eligibility determination, so not whether you agree with the physician that care is needed, whether you need that MRI or that procedure or the like, but just about your eligibility determination. You agree that you need the MRI, but where do you go for it? That is actually considered an expedited appeal, and that will be considered within 72 hours because, again, care has been decided, and we want to expedite the decision of where you can actually get that care scheduled so we can make sure you get it in a timely fashion. If it is about a question of whether the care is clinically appropriate, that appeal might take a little bit longer, but that's a bit more justified because there may be a little bit more background research that needs to be done as to whether or not that surgery is appropriate. You know, the clinical leaders at the facility may need to look through the medical record, and that may take a little bit of more time. So we have this appeals process, but we separate out the time frame in which specific decisions need to be taken, and we definitely agree for eligibility to be able to get the care in the community, that needs to be an expedited decision.
Where should I hear the answer? If I appeal it, what should I expect to happen in terms of the form of a decision, and who should that come from?
That decision will come directly from, we call them the chief of staff, the head doctor at the facility, and then will go directly to the veteran.
No?
Well, I think we're at the, I think we intended to begin the conversation more than try to answer everything because there's so much more to be learned about this new act, and hopefully we can be a good resource for all of our viewers out there to come and get more information, particularly when you've got questions about eligibility, because we don't want folks accessing care and incurring expenses that they shouldn't. But what's the takeaway? And when you all were a big part of making this happen, what do you want the big takeaway to be for everyone watching right now?
I want veterans to know, and I'll say this veteran to veterans, that VA is getting stronger for veterans. This is about VA leading the future, really, in U.S. healthcare. VA has been a leader in many spaces for a long time, in innovation spaces, in telehealth, in the way we've developed our ability to be transparent about our access to care, and made ourselves extremely accessible and high quality. But this is about leading the future as we move toward bringing that access closer to home to everyone. This is about moving across state lines and beyond brick and mortar right into someone's living room to really meet them where they are. And I think the takeaway here is that this is really empowering veterans in a new way, that they are truly at the center of this change in a way that is not just unique to VA, but it's unique to U.S. healthcare. This is really leading the future. And we are welcoming people into VA to be part of that with us. We thank you so much for your partnership in helping us lead that change. And we really look forward to the future. We look forward to delivering this.
I think the point from a community care standpoint, I think the takeaway is that your voices are being heard.
Yes.
We definitely recognize that we have had significant shortcomings in the choice program, and we own that. We recognize that, and we know we've needed to make improvements. We value the feedback, whether it's through the surveys that occur after an appointment or communications through a patient advocate or even congressional offices. We value that feedback because it helps us improve. It helps us know where we need to improve. But please know that VA will continue its lifetime commitment to serving veterans throughout your entire lifetime. As opposed to other health systems, we are here to provide not only health care but other benefits, other social support that unlike any other health system we are able to do just in an incomparable way. So VA will stay at the center of your care, and we will work to integrate how that care is provided both between the VA and the community providers. So again, the veteran stays at the center and that your outcomes and your well-being are preserved.
Thank you.
Well, thank you very much. And I just want to remind our viewers, we're podcasting or Facebook Live just like all the other organizations here, that if you have questions, I think folks will still be able to ask questions even though when we cut off, correct?
Yes.
Yes, exactly. And actually, we invite our viewers to stay on. We will make sure that all of those questions are answered throughout the week. I just want to take one more moment to just say thank you for joining us here today. Thank you for being with us. Thank you for the representation and the voice that you bring into this space, and again, for helping us lead the way forward. And thank you to our viewers for joining us today. Again, we will follow up on those questions, and we really appreciate the time you've taken and your interest in this. Thank you.